Welcome back to this last video on the digestive system. So we're going to do the large intestine, some diseases, and then a final overview. So the large intestine is only about 4.5 feet long, and it starts in the right lower quadrant of the abdomen where the small intestine enters it. There's a little piece that's lower than the small intestine called the cecum, from which the appendix hangs down. Then it goes up the right side of your abdomen to about the liver, crosses across the top of your abdomen, and then goes down the left side of your abdominal wall. Then it has this S-shaped part to get back to the midline. And then all that part going up, across, and down, that's all considered colon. Once it's back in the midline, then this last part is considered the rectum. So all of that is the large intestine. When we look at the histology of the large intestine, it still has the same 4 layers, but there's a huge difference between the large intestine and the small intestine, and that is there are no villi. So remember, we had those 3 modifications in the small intestine. We had there's circular folds, we had the villi, and we had the microvilli because we were doing all that secreting and absorbing. Well, we don't need all that stuff. We're not doing much secreting, and we're only doing a limited amount of absorbing. So what are the functions of the large intestine? Well, we're not absorbing any of the nutrients from any of the foods that we have eaten. We are absorbing a significant amount of water, however. The small intestine has done a lot of the water absorbing, but there still is a lot of water left by the time it enters the colon. You know that because if you have diarrhea, it's watery, and that's because there's still water when it enters the colon. We also are absorbing vitamin K as well as B vitamins that are produced by the bacteria that are in the colon that are still breaking down some of the food stuff. And so their side products are to produce some B vitamins as well as vitamin K. And the biggie is to form feces. So the way it is you think feces is solid, but it's not meant to be a porcupine ball that hurts when it comes out. It's actually only about 1/4 solid waste, and it's still about 3/4 water. It's quite soft when it's formed and it comes out. So going up the right and across the transverse colon, a lot of the water is absorbed, and a little bit more is absorbed as it comes back down towards the rectum. So what is left in the feces is bacteria, dietary fiber that can't be absorbed, and other indigestible materials like corn can't be digested, some seeds, some nuts. And then we're going to have a little bit of temporary storage of feces in the rectum before we are going to be defecating through the anus. So the anal canal is right below the rectum. And if we look at the rectum, you can see it kind of has like these little shelf areas in there because it does. So when feces comes along, it kind of sits here on these little rectal shelves and will kind of stretch out the rectum a little bit. Notice surrounding the lower part of the rectum, there are some sphincters there. And in fact, there are 2 sphincters, and they're not like this on top of each other like this, but they actually surround each other. And here's what's very interesting. The sphincter that is directly around, so like if this is your rectum, the sphincter that is around the rectum itself is involuntary smooth muscle. And then there's another sphincter that goes around that is skeletal muscle. So we have both involuntary and voluntary muscle down there, right at the anus. So here is what happens with the innervation. Your fecal material comes down and sits here in your rectum and kind of distends the rectum. And these blue nerve fibers, these are sensory afferent fibers sending messages up to your spinal cord saying, oh, we are being stretched here in the rectum. And they send a parasympathetic message down to the internal sphincter, which was smooth muscle. And it has that smooth muscle relax as a result of the stretch of the rectum up above. So the only thing that's keeping the poop inside is the fact that that outer external sphincter is skeletal muscle that you can voluntarily keep contracted until you hit the toilet, because that is different. That's this red voluntary motor thing right there. So when we are potty training children, we want to potty train them to release, to relax this muscle. So don't be going around telling your kid, hold it, hold it, hold it, hold it, hold it all the time, because they will become experts at holding it. Instead, you want them to become experts at relaxing and pooping on demand, not experts on holding it. Okay. All right, so that brings me to colon polyps. So starting in middle age, everybody is supposed to start getting a colonoscopy. It used to be a 50th birthday present. Now it's a 45th birthday present. It may soon be a 40th birthday present. And colon polyps are when the mucosa starts undergoing rapid division and forming little tissue growths. And so here's a small one that's maybe, 2, 3, 4 millimeters. And here's one that's about a centimeter in size. And what happens as fecal material goes by this, they can pull on the polyps. And then what often happens is the polyps end up being on little stalks. So you can see on this one, like the normal colon mucosa, you can see the polyp right here, and you can see that the mucosa here is a lot darker. So it's not totally normal colon mucosa. And you can tell it here because it's a darker red. It's not the normal colon mucosa, okay? So it's not normal, but it's not cancerous. It's in that pre-cancerous kind of thing that's going on. And so basically, the size of the polyp generally correlates with the risk of cancer. When they are small like this, it's extremely low risk. By the time they get to this size, 1 to 2 centimeters in size, they start getting to medium risk. And then once they're 3 centimeters inside, start getting pretty significant risk. Okay, but if they're on a stalk like this, the risk is much lower because, the cancer is going to be way out here and not back there. But a lot of polyps aren't on stalks. Oh, and by the way, if you've got this many polyps, it really doesn't matter because you have so many polyps that you can't follow them. You can't take them out. The advantage to these little guys is you can put little snares around them and take them out and they're gone. But if you have thousands, you can't possibly take them out. You have to take the whole colon out. Okay, and this is a genetic disease where you have all these tiny little polyps. All right, so the other type of polyp is one that's not on a stalk, and that one has a much greater risk with malignancy and doing bad things to you, because if you compare these two, if this one has a cancer way up here, it's not likely to invade down there. But if you take the same size cancer and put it in this one, you can see that it will have invaded normal tissues down there. All right, so looking at progression, if it's less than a centimeter, there's on a polyp, especially on a stalk, there's almost no chance of cancer. By the time it's 2 centimeters in size, we're looking at 5 to 10% progression. By the time they're 3 centimeters in size, we are looking at almost 40% chance of cancer progression. And to go from 2 centimeters to 3 centimeters is usually about 10 years. I know some people who have gone from nothing to 1.5 centimeters in 5 years. That's very fast growing. And those are the kind of people who need to have colonoscopies every 2, 3, less than 5 years, because obviously they've got something going on where their cells are growing very fast. When we look at adults with colonoscopies, only about 25% will have polyps present, and those people need to be followed much more often. So this was how things used to look until about 5 years ago or so, until we realized the whole field of colon cancer was changing, in that there was this huge rise of colon cancer in young people, as in people under the age of 40. Because we never used to worry about colon cancer in people until they were in their 50s and 60s, which is why screening was never done until 50, and then it got dropped down to 45. And now we are looking here, if you would look at 2020, this is what has happened to the risk of colon cancer. For 20 to 34-year-olds, it has gone up about 40% higher. And for 35 to 50-year-olds, it has gone up about 15 to 20% higher. Whereas for the older people, the incidence has gone down. Why? Because the older people have been getting colonoscopies, and they have been followed, and they have had the dietary change, and we know what's going on with them. We don't know what has happened to these young people. What has changed in their risk factor? What is their dietary change? Something massively has changed to cause colon cancer in our youngsters, okay? Because now, if we follow our line predicting out from where it was in 2020, and we follow 2023 to by the time we hit 2030, the chances of colon cancer in 20 to 34-year-olds will be 90% higher, and rectal cancers will be more than doubled what it was in 2010, okay, from when they were born, okay? So those numbers are atrocious, and their symptoms are different. Classically, it used to be constipation and a little bit of, it wasn't rectal bleeding, but it was, you would test for blood, but people didn't have bright red blood. Now, what we have in the young people, they actually have rectal bleeding, and they think, oh, it's hemorrhoids, it's nothing to worry about because a 35-year-old can't have colon cancer. But we are finding they have rectal bleeding, they have diarrhea, they have abdominal pain, they have anemia, and especially a young female, we think you're anemic from your periods, only now we're finding you're anemic because you have a colon cancer. So it's not a good thing. The normal risk factors still apply: obesity, a sedentary lifestyle, alcohol intake. We know our young people have a much higher alcohol intake than the older people. Smoking and vaping, dietary fat, low fiber diet, red meat 5 times a week. Become vegetarian. Your colon will thank you. Weekly preserved meats. Are you having ham, cold cuts, hot dogs, salami, any of those things more than once a week? That's a risk factor. Bacon. All you bacon lovers out there, risk factor for colon cancer. So here is what a colon cancer looks like on a colonoscopy. Here is a sectional colon that was taken out. We have a small little polyp on a stalk, not a problem. We have a big polyp, may have some cancer cells in it. It's kind of nasty. It's about 1.5 centimeters in size. And then this is a very obvious, really large 3-centimeter cancer here. Here is another cancer, and this one has invaded and ulcerated at the base. And here is one you can see. This one is about, I don't know, 5 or 6 centimeters long. And look how narrow it has made the colon. Like, this person's poop, instead of being the normal diameter, has been like a skinny little poop for a long time. This person should have been seeing their healthcare provider. So risk reduction, now everybody needs to start at least by age 45. If you have a family member diagnosed with colon cancer, you need to start 10 years before the youngest family member. So if you had a family member diagnosed at age 50, you need to start at age 40. If you had a family member diagnosed at age 40, you need to start screening at age 30. If you have any kind of bleeding, any kind of change in your bowel habits, whether it be the diarrhea, whether it be the constipation, whether you're gone from having 1 bowel movement a day to having 2 or 3 a day, or from having 2 a day to having 1 every other day. If you've had an unexplained weight loss, if you have any unexplained abdominal pain, get your routine screening done. Eat a balanced diet. By that, we say eat the rainbow, all the different colors of fruits and vegetables. Avoid any kind of smoked meat, any kind of smoked fish. Not so popular here in California, but in Asian countries, smoked fish, and in the Midwest and southern parts of the United States, there's a lot of smoked meats. Saturated fats, very bad for your colon. Ignore processed foods. Oh, processed, fast foods. Don't eat them. They're bad for colon cancer, and limit your red meats. And by your red meats, I don't just mean beef, lamb, venison, and boar. Okay. So yes, chicken, turkey, and pork don't increase your risk for colorectal cancer. And change your habits. Reduce your alcohol intake, quit your smoking, your pot, and get enough exercise. So you're looking at 2.5 hours a week of moderate activities and 2 days of strength training. Okay, this I just thought was a cute sign of someplace in Europe. I forget where, someplace in Eastern Europe when I was about your age. Okay, for a summary, here is that picture I used at the beginning to talk about all these steps of food processing. So take a minute and look at the words and make sure you can explain all of it. And then I put in table form all the different parts of the alimentary canal, added in the accessory organs, put in different types of mechanical and chemical digestion. I forgot to put in here with the pancreas, I forgot to put in the bile for the mechanical digestion, the emulsification. So you definitely make sure you add that in. If I put in any other chemicals, add those in, and then add in specifically what nutrients, don't just write nutrients, put in specifically what nutrients are being absorbed. Okay, flesh this out to what we talked about in class. And that is it for this. I'm ending with a joke, so I'll leave it up long enough for you to read it. And I want to thank you so very much for all your hard work in this. And want you to realize that I divided the digestive system over 2 days because it would have made for one really long day, but over 2 days, it made for 2 really short days. So enjoy. Thank you.